Good morning, East Africa. I hope that you woke up very well this morning. First of all, happy new month. We are in the third month of the year 2022, so I hope the entire month of February has been good to you so far, and you hope to have an amazing month. That is the month of March. Thank you very much, as always, for joining us. This is Your World, and my name is Winnie Lubemba. Looking forward to an amazing show today on a very, very essential conversation that we need to have as far as the cancer burden in the country and, of course, understanding that treatment that comes with it. Now, the cancer burden is rising globally, exerting significant strain on populations and health systems at all income levels. In Kenya, cancer is the third leading cause of death after infectious and cardiovascular diseases, with 70 to 80% of patients diagnosed for treatment at an advanced stage. So this has been attributed to, among others, low awareness of symptoms and availability of cancer treatment, low rate of treatment acceptance and adherence, low index of suspicion by health providers, and high cost of treatment as well. So what exactly does cancer treatment involve, and what can be done to bring down the cost? Well, we unpack all that in today's special edition of Your World, where we'll be joined by Lois Wangui and her panel live from Eldoret. There she is, ready for the discussion. Lois Chamge.
Me sing, Winnie, I hope you're doing well, and of course I wish you a very, very lovely month of March. As you noted, this morning we discuss matters to do with cancer, and our focus this morning is understanding the treatment of cancer. Winnie, gone are the days when cancer was a disease of the rich or well-to-do in society, and now yourself, myself, and our viewer have directly or indirectly been affected by cancer, and so it is very important that we understand how the management and treatment of cancer goes. You gave the statistics earlier, and the Ministry of Health in the country also recognizes that cancer is the third cause of deaths in the country. But I was speaking to my panelists here earlier, just before this live production, and Dr. Sarah Obuya, a clinical oncologist who's here with me in studio, was telling me people need not die from cancer. And as we have this conversation, she will be telling us why and what are the options and how people who have been affected by cancer, what they should understand to ensure they are able to manage and treat cancer effectively. Also with me in studio is Esther Andare. Now, in the year 2015, Esther Andare was diagnosed with ovarian cancer, but she is strong, healthy, going about her daily activities, and this is as a result of going through cancer treatment and management. So it is possible to get over or to get through cancer treatment and management. And how do you do that? My panelists here, also among them Rose Wekesa, a radiation therapist, will be talking to us and giving us insights so that we understand immediately after getting that news that a loved one or even yourself has been diagnosed with cancer. Where do you start? Where do you begin? What are the steps to be taken? And of course, the story of Esther here will add the much spice that we need to this conversation, that it is possible to manage cancer effectively, and for those diagnosed with cancer to go about their daily lives after proper treatment and management. For now, back to you, Winnie, in studio. But for our viewers, I would like to know, have you ever gone for a cancer screening? And if not, would you volunteer to go for one? I think those are one of the areas that the government is looking to really do a lot of work in. We need to ensure that the walk-ins in hospital increase in numbers, in people volunteering to just go for cancer screening, because as it is, 70% of those diagnosed with cancer in the country are always at an advanced stage. So the ministry advises for people to go in much earlier for early diagnosis. So that is a question of the day. Let me start with you, Winnie. Have you ever gone for cancer screening? And
yes,
have you considered? If not, have you considered to go for one?
Yes, I have. And let me tell you, it is one of the scariest, if there's a word like that in English. It's very, very scary to just, first of all, take that step to go for cancer screening. But I went for breast cancer, and it was, you know, know, it was very scary, but at the same time, very, very necessary. And I like what you said earlier on, that majority of the people actually do not go for screening. And this is one of the biggest problems that, you know, we are facing as a country, so that by the time one gets a diagnosis, it's at a later stage. So, and like you said earlier on, people need not to die from cancer. So I think spreading the message as far as screening is concerned and early diagnosis is very, very, very important. So of course, Lois will be coming with the rest of the conversation, but for now, let's take a look at the day's highlights. Now, the Ministry of Health holds a high-level consultative forum to assess the country's preparedness in treating cancer locally. And cancer is the third leading cause of death in Kenya, as the country loses over 27,000 people every year to cancer, according to the National Cancer Task Force. And Kenyatta University Teaching, Referral and Research Hospital becomes the first public hospital in East and Central Africa to conduct cancer screening using PET scans. All right, and of course, I understand that today we'll be talking about cancer, but how about we take a look at the COVID-19 situation? This is across the globe. Remember, this is a pandemic that we're still dealing with. So let's begin with the global figures as far as COVID-19 is concerned. And up until now, 437,071,664 people have so far been confirmed to have COVID-19. And this is the first case since the first case of COVID-19 was reported. And then 368,190,585 people have recovered from the same. But unfortunately, 5,975,033 people have lost their lives to COVID-19. But when we come back to the country, as far as the global figures, the numbers, that is, as far as COVID-19 is concerned, that is the numbers in the country, according to the Health Ministry, which releases the statistics every single day. This is what we are looking at as far as COVID-19 numbers, that is in the country. This is as far as COVID-19 is concerned. All right, so according to the Health Ministry, and that is the statistics as far as on Thursday, because again the numbers gets released every single day. This is according to the Health Ministry. We'll be taking a look at it in just a moment. But for now, on cancer, well, Kenya's cancer management is set for a big boost after the Ministry of Health held a high-level consultative forum to assess the country's preparedness in treating the disease locally. According to the Ministry of Health, Kenya still lags behind in diagnosis and treatment of the non-communicable disease that is the third leading cause of death in the country. Addressing the gaps, the few oncologists and making cancer treatment affordable have been listed as a priority, as well as cancer prevention. The National Health Insurance, that is NHIF, says it will be expanding the treatment services for cancer patients.
Even lifestyles are part of what we must discuss, because we want to deal with prevention, we want to deal with surveillance, we want to deal with diagnosis and treatment. But if we can prevent this disease from attacking our people, it will reduce the burden both to the families and to the government.
We're even looking at expanding and even including some of the preventive measures like mammogram, for example. But with the current covers that we have, it covers both pre-tests and post-tests. It covers chemotherapy, both complex and basic. It covers diagnostics up to PET scans. And you know that many people were leaving the country previously to go abroad to do PET scans, but right now it's available here.
And still on the same, cancer is the third leading cause of death in Kenya, and this is according to the latest data from the National Cancer Task Force. The task force has also identified breast, cervical, prostate, and esophagus and colon cancers as the most common ones, accounting for about half of the cases. Martin Mwangi with the details.
27,000 people every year to cancer. This is according to the National Cancer Task Force. Another 42,000 new cases are detected every year, with concerns amongst the medics that the cases are on a rise due to the poor eating habits and changing lifestyle. Some milestones have been made in their detection and treatment, but the task force says a lot more needs to be done.
Such a high burden then calls for us to think about some of the interventions that we can put in place. As a task force, we have been able to visit hospitals that are providing cancer treatment. We have been able to engage with counties that are providing care. We have been able to engage with different agencies in government, especially agencies that are related, that have a bearing on cancer control.
While presenting its reports to the stakeholders after a year of taking views across the country, the task force said cancer was the third killer in the country after infectious and cardiovascular diseases. Breast, cervical, prostate, esophagus, and colon cancers are taking the lead with 45% of the cases. 6,800 cases of breast cancer were recorded last year, followed by cervical at 5,200 and prostate at 3,000. The government has been opening up more cancer centers in the country for early detection in a bid to reduce the cases.
We have two PET scan machines, and each PET scan machine can scan 24 people per day, which means we have the capability of scanning 48 people per day. Since we started about a month ago, we have scanned 200 Kenyans, over 200 Kenyans, and these Kenyans are the ones who would have gone to either India or South Africa for scanning. Kisumu Governor Anyang' Nyong'o called on the National Health Insurance Fund to support the cancer patients.
There's no need calling yourself National Health Insurance Fund when you are not covering health. All you are doing is covering diseases, a very morbid way of looking at health. It is health that we are insuring. And if we do that, then preventive health and family health and community health becomes a cardinal aspect of health insurance.
The task force identifies cost of treatment as the main challenge facing cancer patients. Martin Mwangi, NTV.
And Kenya joined the rest of the world in marking World Cancer Day on the 4th of February. At an event in Mombasa, the government noted its efforts towards cancer treatment in the country. One person who has been through the cancer journey is Ruth Waitherero. Here's Lois Ongoi with her story.
The year 2015 remains significant for dairy farmer Ruth Waitherero.
2015 ndio nilipata hii ugonjwa ya kansa. Nilipata ka kitu hapa, ka uvimbe kalikuwa hapo kwa matiti. Siku nilipewa hizo results, hata chakula kuna mtu kwa boma alikula. Tulipika chakula hata umbwa ya huku haikukula.
Thee's wife and mother of one says she had no time to even digest their diagnosis that would change her life.
Daktari alienda akaniambia, sasa hapa mama, sitaki kukupeleka shortcut. Nataka kukuambia ile ukweli. Hii ni kansa na iko stage 2 na inavaa hiyo kitu itolewe mara moja.
Cancer diagnosis bears with it shock and fear, not only for the patient but to communities around them. It was no different for Ruth.
Nitasikia tu kama nimekufa au ni aje. Hiyo kuambiwa tu uko na kansa, mtu anasikianga hapo kama umekufa. Unajua mtu ananga hiyo hopes ati unaweza aka
Ruth's treatment involved a breast removal surgery, 12 chemotherapy sessions, and 21 radiotherapy sessions. So, to keep herself healthy, her lifestyle and diet had an overhaul. The country's National Cancer Day celebrations were held in Mombasa County.
Access to health was not there. Access for health, for treatment of cancer was not there. But today, here in Mombasa, we are glad to hear that access to cancer treatment is right here.
In Uasin Gishu County, various stakeholders held a procession to mark the day.
Then we will make sure that we diagnose early at probably stage 1, stage 2. When it gets to stage 3 and 4, unfortunately, cure becomes a bit elusive.
Ruth's wishes to the government is no doubt one that many share for an increase in radiotherapy machines in the country to battle the disease. Lois Wangoi, NTV, in the county of Uasin Gishu.
And of course, Lois Wangoi will come back with more details as far as the discussion on cancer is concerned. But for now, Kenyatta University Teaching, Referral and Research Hospital has become the first public hospital in East and Central Africa to conduct cancer screening using PET scans. The new machines are able to detect cancerous cells in the body faster through imaging. One will be able to know their health status much earlier and boost chances of beating cancer. Now, NTV's health and science reporter Helen Aura has more details.
The burden of cancer continues to be a thorn in the flesh for many Kenyans, condemning families into financial oblivion as they seek to have access to treatment. Now, the Kenyatta University Teaching and Referral Hospital has begun cancer screening using PET scans to help with early diagnosis.
We have decided to be doing 2 shifts, and that way we will be able to scan about 50 Kenyans per day using the 2 machines.
According to data from GlobeCan Kenya, the leading types of cancer in the country are breast cancer, cervical cancer, prostate cancer, esophagus cancer, and colorectal cancer. With cervical cancer being the leading cause of cancer deaths in the country among women, and prostate cancer the leading cause of cancer deaths among men. The PET scan machines will help doctors know the metabolic activities of the particular tumor, as well as the exact location, further detecting abnormal cells in the body.
We get a referral from the oncologist. We inject the patient with something called as FDG, fluoroxydeoxygen glucose. And this is the one which gets concentrated, it's a glucose analog basically. It gets concentrated in the cancerous cells in the body. So depending on the area of affection is what the doctors now decide where the treatment should be given.
Once injected with the FDG, the patient becomes radioactive.
So once the patient is injected, we give them around 55 minutes to 1 hour for the uptake time, what we call as an uptake time. And this is just mainly to make sure that the glucose is disseminated in the body and concentrates in the area of need. Usually the scan time is around 25 minutes.
We will be charging 40,000. So if you have it approved by NHIF and you come here, you will not be required to add. But for now, we will charge that and then work with the NHIF to see whether they can increase that amount for us.
Patients who will pay cash for the services will be charged 55,000 shillings, while those under private health insurers will be charged 60,000 Kenya shillings for the procedure. Helen Aura, NTV.
And of course, the primary goals of cancer treatment are cure, prolongation of life, and improvement of quality of life. The most effective and efficient treatment is linked to early detection programs, which is the greatest challenge. So then how do we reverse this? Well, Lois Wangoi will be coming up with that discussion in just a moment. And remember, the question that we're asking you is, have you ever considered going for cancer screening? If so, tell us the experience. But we're taking a short break right now. We'll be back with more. Stay with us. This is Your World.
many cases have you taken to court?
Gentlemen, 453.
And one conviction. You should be disbanded.
We do not prosecute. Our office to investigate.
The biggest enemy that the Kenyan people have is not malaria, is not HIV, is not COVID, it's politicians.
In as much as Boris says we should elect good leaders, what if we are not good ourselves as a country?
God has no voter's card. God will never elect anyone. The devils that you think you need to be scared of are the devils that you elect.
The impunity we have, we blame them. Look at our roads. The impunity about our borders, the matatus, how we drive, everything we do. Impunity is rampant everywhere.
The law must be seen to work.
This country is bigger than you and your party.
Join the Daily Nation team in wishing our candidates success in the Fauluna Daily Nation campaign. Log on to success.nation.co.ke from your phone and send the candidates' details and a heartfelt personalized message for only 299 shillings. Or include a photo of the candidate for only 999 shillings. The messages of hope will be published in the Daily Nation Junior Sport magazine every Monday. Campaign runs from 21st February till 28th March 2022. To advertise and for school rates, kindly contact 0719 038 678 or email successcard@ke.nationmedia.com. Tusimame na watoto wa Kenya na Daily Nation.
With this year's International Women's Day theme being Break the Bias, the next episode of NTV's Business Redefined focuses on gender equality, which requires equal enjoyment of socially valid goods, opportunities, resources, and rewards. To push this gender agenda, I, Nina Shaban, will be having a sit-down with Anastasia Kimutai, Director Retail Business, KCB, Lauren Onduru, Head of Communications, UBA, and Jadaya Morania, Chief Executive Officer, Kenya Re. Join us as we discuss women in enterprise and mainstreaming the gender agenda in the business environment. Business Redefined on Tuesday at 7:30 p.m. With this year's International Women's Day theme being Break the Bias, the next episode of NTV's Business Redefined focuses on gender equality, which requires equal enjoyment of socially valid goods, opportunities, resources, and rewards. To push this gender agenda, I, Nina Shaban, will be having a sit-down with Anastasia Kimutai, Director Retail Business, KCB, Lauren Onduru, Head of Communications, UBA, and Jadaya Morania, Chief Executive Officer, Kenya Re. Join us as we discuss women in enterprise and mainstreaming the gender agenda in the business environment. Business Redefined on Tuesday at 7:30 p.m.
Why didn't you tell me anything, Cardenas?
Please, Kata, it's a question of security. The less people involved in this, the better.
If you have something to tell him, you can write a note and I'll take it to him if you like. No, I don't want to write him a note. I need to see him.
Oh, so now I'm to blame for every terrible event that happens in this town? Stop blaming me, Pablo.
Just as your friends returned the favor by giving you the recording, why wouldn't they plant evidence against Pablo?
I don't care what you think, but if you don't follow my advice, then you will pay very dearly for your insults.
Is that what happened to Cardenas when he was a cop?
Who is this guy? First feedback I got was he's very fast.
The world will be looking at Ferdinand. I saw the African record going down.
Kama mzazi lazima ufurahie.
I don't know what I was doing in volleyball, but it took me like a month or two
to now accept myself that I'm an athlete. Unajua wanasemanga huwezi ingia gym na bado vengo bagi. Lazima muscles zionekane. My name is Ferdinand Omanyala and this is my story.
6-7 games in a match.
I'm really proud of what I've achieved and the me I've become.
Angela Okutoyi of Kenya, like the Serena Williams of the US.
The plan was to reach the quarters, I was one match away to achieving it.
Very difficult for her to practice with the girls that we have because the level is tremendously high. She practices with the Davis Cup players who are actually men and not even boys.
I would like to congratulate Angie once again for bringing glory to the name of Kenya, which is well known as being an athletic country.
If I have made it, you can also make it.
Ili tuendeleze maisha bora kwa ajili ya wapendao, nchi yetu na usoni wetu, kwa ajili yetu sisi sote. Pata chanjo, kaa chonjo, kuhakikisha nchi yetu na uchumi wetu umestawi katika uwazi. Tusirudi nyuma.
Welcome back. Thank you very much for staying with us. This is Your World, and today is a special edition of the show where we are focusing on understanding cancer treatment, because again we have mentioned a number of things that have been an impediment as far as cancer treatment, that is access to cancer treatment, is concerned. So right about now, the question that we're asking you is all about, have you ever considered going for cancer screening? Once again, have you ever considered going for cancer screening? If so, tell us your experience. If not, again, tell us why you have not gone for screening. But for now, again, that is the question of the day on your screen. Have you ever gone for cancer screening, and would you go for one? That is the question that we're asking you today. So at NTV Kenya, at Lubembe_Winnie is how you can reach us, and as well feel free to call in. So Lois Angui is in our Eldoret studios ready for the discussion. So Lois, take it away.
Many thanks, Winnie. And first, let me introduce my guests this morning to help us understand better cancer treatment. Seated next to me is Dr. Sarah Obuya, a clinical oncologist. Many thanks, Dr. for joining us. We also have Esther Andare. She is a cancer survivor. Esther, thank you for being here. And we also have Rose Wekesa. She is a radiation therapist. Dr. we start with you and we go right into understanding cancer treatment. Earlier we were having a conversation and you noted the first point, or where oncologists begin when it comes to cancer treatment, is on the issue of acceptance. Please talk to us about how important it is for a cancer patient to accept their situation even as they await doctors' advice on their mode of treatment moving forward.
Yes, good morning, viewers. The most important thing usually is to listen to your body, because most of the time you listen to your body, you will pick up clues that there's a problem that will take you to the hospital. But do not wait for that, because there are structured screenings and there are campaigned screenings. Every so often we go outside into the field and screen people, and it is amazing how many people we have picked from field screenings. Having said that, when a diagnosis of cancer is done on you, just like any other illness, it's of utmost importance that you get to understand what is going on with you. Why should you understand what's going on with you? So that you are able to accept the journey, because cancer diagnosis, management, and follow-up is quite a journey. We stay with our patients for a very long time. In fact, most of the times they become our very close friends. We develop feelings of being there for one another. And this important step of accepting the diagnosis is so crucial that it will make the difference between you surviving the illness or succumbing sooner than you ought not to have succumbed.
Okay. All right. So, Esther, the year is 2015, and you're diagnosed with ovarian cancer. Tell us how your journey began. Was it a voluntary walk-in, or did you have symptoms that prompted you to go to hospital?
Well, mine was started much earlier. Of course, with the symptoms that were there, I was not able to catch up on it. But when it started, I was pregnant with my second-born child. And for some time, I was diagnosed with quite a number of things, in which sometimes were diagnosed as persistent UTIs, missed abortions, bleeding throughout sometimes the pregnancy. And for some time, you know, it looked like the normal kind of symptoms any pregnant woman would maybe have. But after that, after giving birth, now the abdominal pains persisted. The bleeding persisted. Sometimes these abdominal pains would be really, really bad, affecting even the back, sometimes even my ability to walk properly, to do my work, my normal routine. So one day as I'm just relaxing, I have a sharp pain on my left, and it was quite a persistent pain that was not letting up. That pain that continues on and on. The more you sit, the more it continues being worse. So that was the first time now I had to rush to hospital. So from that diagnosis, the first doctor I saw said it could be appendicitis or maybe an ovarian cyst that is twisted. So in my head, quite frankly, I thought it was just that. I never expected. My family had no history of cancer. So and from even the people I've interacted with, people never quite believe that you can get it. It always seems like it's the other person.
Until it is you.
Until it is you. So after that, when I was rushed to the hospital, now for the removal of the cyst, that's when they realized, that it was cancerous.
All right. So that day you went home after the removal of the cyst, and I want to believe our doctors now took that particular...
They went ahead and performed the full hysterectomy, and then now after that, now they followed it up with the treatment. There was no time for me to think about it. But now after I came to, when they told me, now the hardest part...
what duration is this from the moment you...
You see, now when it was a cyst, because it was very painful, the way to go about it is to remove it, remove the affected ovary.
Then you went home?
Yes. Before I went home, they sent the sample to the lab for histology. So I went home, and afterwards, after 2 weeks, they called me back and they tell me the results.
All right.
Yes.
So were you alone? And if you could paint a picture for us of that particular day, your third doctor is telling you now, here, Esther, I think there's this problem. How did you take it?
It was a shock. Honestly, I disappeared for 2 weeks. I didn't go back to the hospital. I stayed away from friends. I didn't tell my parents. And then, you know, also this is something that for some time, when people talked about it, it belonged to a certain caste.
Social class.
So you start asking yourself questions on why you, why at that age. I was as still quite young. And of course now you look at the people who have been through it. You start getting afraid because because my greatest fear actually about the treatment was losing my hair. But I didn't look at the other factors until I started a treatment.
Okay, thank you, sir. And we'll come to your experience of the treatment. Daktari, the options that we majorly see being advised to cancer patients is chemotherapy, radiotherapy, and surgery. I want us to start with radiotherapy. How and when does a cancer patient get advised to do radiotherapy, and how do they go about it?
Thank you so much. So I would like viewers to understand that radiotherapy is actually a local treatment, and it is also a palliative treatment. Palliative means that a patient could present with like obstruction from cancer, so they cannot breathe well, so we can take them for an emergency radiotherapy. Or they are bleeding so much from their cancer, so then we take them for emergency radiotherapy. Having said that, radiotherapy is basically a local treatment. It means that your cancer has been staged. There is something called cancer staging. When we make a diagnosis of cancer in a patient, then there are several tests that we run. We put this together according to a scientific criteria, and then we say this cancer is stage 1, 2, 3, 4, or it is metastatic disease. And you are sent for radiotherapy when your cancer is fitting in one radiation field, which means at most, for most cancers generally, we hardly radiate beyond stage 4.
Stage 4?
Yes.
Okay.
Yes.
So if you're in stage 1, 2, 3, you qualify for radiotherapy?
It depends on which cancer that you have, because not all cancers are radio responsive. There are certain cancers that are very radio resistant, and there are others that are radio sensitive. So for the radio sensitive cancers, we stage you, and then if you fit in one radiation field, then we do something called workup. And then when we find you fit, we can now send you to the machine. It's a whole science and technique, because it's not just a matter of sending you to the machine. We have to know exactly where your cancer is, because it is a precise science. It is precise in that when we put you under that machine, the cancer must get the full dose of therapy. While you are doing that, you must protect the organs that are surrounding the cancers. For example, if you're subjecting a patient for radiation for cancer of the cervix, you want the tumor, the growth itself, to receive maximum dose acceptable for that cancer. But at the same time, you want to protect the rectum, you want to protect the bladder, and you want to protect your head of femur. So it's a precise science with the dosages, just like, you know, when they give you antibiotics, they tell you, take this drug this so often for this number of days. So in radiation, we have doses that we call grays. So you can have 1.2, 1.8, you know, 2 grays per session. A session is that you go on the machine once each and every day, except on public holidays and weekends, for the total number of radiation doses that you have been
has advised.
As advised. And the doctor advises according to the type of your cancer. You know, it is not just enough to say that a patient has for example, cancer of the breast. Cancer of the breast is a whole syndrome. We need to test you and know, are you hormone receptor positive patient? Are you a HER2 positive patient? Are you a triple negative patient? And if you are, is your cancer just localized in your breast, or it has gone through the skin of the breast, or it has gone into your lungs, or it has gone into the surrounding lymph nodes. So it's a whole syndrome. It is actually such a fallacy just to say, you know, I have cancer of the breast. Yes, there is much more.
There's much more. And Rose, I want to imagine this is your daily life, radiotherapy. I'm sure you have amazing stories of cancer survivors and people who have gone through the treatment successfully, and also sadly, cancer patients who have lost the battle during radiotherapy. Talk to us about radiotherapy from where you sit. How do you appreciate its contribution when it comes to the treatment of cancer?
Okay. I think I will first start by echoing Dr. Sarah's words. She did mention that the intent of the radiotherapy may be to completely eradicate or for long-term control, and the other one is for palliation of symptoms. Rather than just looking at it for long-term control, I do appreciate radiotherapy whenever we come to palliative treatments. She did mention about obstruction. And if the patients are coming with an obstructive syndrome, for example, you give radiotherapy and you see that relief, patient is able to breathe again and they are back to normal. At least I do appreciate that is a fast relief of such conditions. And for long-term treatment, although it's most of the time it may not be by itself radiotherapy, it's combined with other modalities, for example, surgery or chemotherapy. But we've been able to see that the patients have survived quite a long time. And I think that makes me really happy about what I do on a daily basis.
Okay.
Yeah.
And for the patients who are coming in, let's say for the very first time, do they come to you with a lot of questions? Are they scared? I want to imagine, Dr. was saying you're put in the radiotherapy machine.
Yes.
What are the questions that they frequently ask you when these patients come? What are their greatest concerns when it comes to radiotherapy treatments?
Okay, definitely they do come with questions, yes. And the questions that come, you did start about asking about acceptance. Sometimes you realize that the patients are coming to you, they have been explained the procedure and what it entails to go through such treatments, both chemo, radiation, and surgery. But still, when they come to you, they want to hear what you're telling them as a radiation therapist. So it is quite interesting that sometimes now you have to try. The doctor has taken them through, but they also want to hear from your side. Am I going to get exactly the same what the doctor is saying? Some of them will be optimistic that they are fine, or they will be okay at the end of the treatment, but others, you know, some may have given up. So the acceptance is not there at that particular point. So you have to try every day to keep talking to them about about the expectations, and then the side effect that is related to that. So sometimes when you mention the side effects to the patient, and they're wondering, am I going to go through this? But then it's something you have to tell them beforehand as they go through the treatment. But eventually what we have seen, trying to talk to them on a daily basis, at some point or like midway their treatment, you see that acceptance coming in. Yeah, and then they cope towards the end.
Okay.
Yeah.
So Esther, you're diagnosed with ovarian cancer, and the doctor has advised for surgery and chemotherapy, you had told me. So when you had these interventions being mentioned by the doctor, what came through your mind when doctor said now you require chemotherapy and surgery so that we are able to deal with your ovarian cancer?
The first time actually, now after they gave me the plan for the treatment, you remember now the first surgery they did remove the affected ovary.
Yes.
So now you're being told you have to go back again, so that because there's always a possibility of other areas being affected with
the cancer spread.
Yes, and the cancer spreading. So they look for long-term solutions, and for me, surgery was one of the best solutions at that time.
Okay.
And then now followed by chemotherapy. So, like I've told you, as acceptance, and the doctors keep saying it, is easy and hard at the same time. Easy when they tell you, and when you go back home and you're seated now thinking about it, very difficult. Because it is not like we have no knowledge of the disease for some of us. And we have seen what it has done to other people. So you start comparing yourself with what you've seen, and the thing that goes through your head is death, because the ones you've seen before you have gone through the same journey, and that is now what creates the fear. And also, if you'll have the strength to go through
it. Yes.
And
I want to imagine, were your fears more on the chemotherapy or on the surgical part?
I didn't know what it felt like going through chemotherapy, so I had no fear of it. I was more afraid of the effects.
The side effects?
Yes, that I kept seeing from other patients I'd seen on TV or heard about. So I had no idea what it felt like to go through.
Did you have a particular side effect that you had heard about and you were really, really scared about?
Yes, the loss of hair. I kept wondering how people would look at me, and the fragility of the body after chemotherapy and all.
Okay.
So that was actually my greatest fear before going through the treatment. And also telling my friends and my family members, including my husband, and the response thereafter. Yes.
And you'll take us through that later. Dr. Esther ushers us into the conversation about another mode of treatment and management for cancer, chemotherapy. Break it down for us. What does chemotherapy mean, Dr., and how do you apply it?
Chemotherapy basically means the use of cancer chemotherapeutics. You know, these are drugs that have been produced to fight against cancer cells. And we have several classes of drugs going all the way. There are almost 9 or so classes. So again, your doctor...
the use of drugs?
Yes.
Okay.
So your doctor will look at your cancer and they will tell you that your cancer is responsive to chemotherapy. And once they tell you that, they will choose a combination of these cancer drugs that they will use to treat your cancer. And that combination is actually quite scientific. You mix drug from class A and B and C, and then they work on something called the cell cycle. And basically what they do into the cell cycle is that they destroy, you know, the engines of the cancer cells that make them reproduce. They can destroy that engine, or they can stop the engine, or they can act as barriers towards the proliferation and multiplication of the cancer cells. Now, these chemotherapeutic agents, the ones that you call chemotherapy, they come in various forms. You can have them in tablets. You know, your doctor can tell you that you'll be swallowing this drug morning and evening or once a day for this number of duration. And then we will give you in this number of cycles. There are things we call cycles in cancer chemotherapy. You know, your drug could be every week, or it can be every 2 weeks, or it can be every 3 weeks, or it can be even be daily, depending on your cancer. But the most cancer chemotherapy the people understand is the one that is given through the veins. Probably because it's a process. Before we give you chemotherapy, we have to assess you according to laid down performance statuses. The famous one being ECOG performance status. Because there's a status beyond which you do not qualify to be on chemotherapy. Because then the chemotherapy will be more toxic to you than just leaving you alone. So once we assess you and find that you are fit to have chemotherapy, we have to check that, you know, your kidneys and your liver and your bone marrow is working well. Why is this important? You know, we need good blood levels, you know, like an HB of more than 10 for your drugs to work very well and for you to keep going. The kidneys and the livers are very important because that's where the chemotherapy drugs, once they do their work, they are degraded and excreted out of the body. Why is this process important? This is so important because you can get something called chemotherapy toxicity.
Yeah.
What is toxicity? All drugs are toxic. That's the reason why there's a specific dose and duration. So we have to make sure that the systems that will degrade these drugs in your body and excrete them is perfect.
So, Daktari, that goes to say that before a patient goes through chemotherapy, doctors have to ascertain that their immunity level is at their best.
It really does not have to do with immunity, but immunity is very, very important because your white cell count have to be at a good level.
That's a good level.
The reason is the cancer drugs themselves will make your immunity go down.
Okay, Daktari, I want to cut you at that. We come back to you with more. Daktari, we have tackled surgery and radiotherapy, chemotherapy. When we come back, much more on that, cancer treatment plans and opportunities that are there to ensure that cancer patients understand cancer treatment. We take a short break on Your World, but we'll be back with much more from our Eldoret studios. And remember, give us your contributions and your thoughts. And this morning we are asking you, have you ever gone for cancer screening? If yes, tell us. If no, tell us why. So we go on a short break. We'll be right back.
I'm really proud of what I've achieved and the me I've become.
Angela Okutoi of Kenya, like the Serena Williams of the US.
Plan was to reach the quarters, was I was one match away to achieving it.
Very difficult for her to practice with the girls that we have because the level is tremendously high. She practices with the Davis Cup players who are actually men and not even boys.
I would like to congratulate Angie once again for bringing glory to the name of Kenya, which is world known as being an athletic country.
If I have made it, you can also make it.
Tusirudi nyuma kwa mipaka na nchi kufungwa. Tusirudi kwa biashara na shule kufungwa. Kwa kutoweza kukutana. Kwa kutengana na tuwapendao. Tusirudi nyuma.
Na kuhitaji unikinge, pata chanjo.
Ili tuendelee na maisha vizuri.
Na kuhitaji unikinge, pata chanjo.
Na kuhitaji unikinge,
pata chanjo.
Na kuhitaji unikinge,
pata chanjo.
Na kuhitaji unikinge, pata chanjo.
Ili tuendeleze maisha bora kwa ajili ya wapendao, nchi yetu na usoni wetu. Kwa ajili yetu sisi sote. Pata chanjo. Kaa chonjo. Kuhakikisha nchi yetu na uchumi wetu umestawi katika uwazi. Tusirudi nyuma.
When I'm taking control, I be killing them.
Where to meet?
You got the African sauce, baby. These streets we banded. Baby, boo, I run the city. Stim, zipande. Give them another get on there.
Nisho, ni wapi uliniona? Hi, what's up, beautiful people? This is your girl Nadia Mukami, aka the African pop star. Then you're watching Kwetu Mix ndani ya NTV. Keep it locked, straight up.
Kama kawaii, hatuna maneno kwetu. Tunapendana kikwetu.
Ili tuendeleze maisha bora kwa ajili ya wapendao, nchi yetu na usoni wetu. Kwa ajili yetu sisi sote. Pata chanjo. Kaa chonjo. kuhakikisha nchi yetu na uchumi wetu umestawi katika uwazi. Tusirudi nyuma.
Welcome back to our ongoing conversation on understanding cancer treatment. I have with me in studio, if you're just joining us, a clinical oncologist, a cancer survivor, and a radiation therapist in that order, Dr. Sarah Obuya, Esther Andare, and Rose Wekesa. So earlier, Dr. we adequately tackled radiotherapy and surgery, and we were on chemotherapy. Esther here just giving us her experience, and one of the things that she talked about was the fears because of what she had read or seen or heard about when it comes to chemotherapy. The side effects, Dr. Seem to be of great concern to patients, more than even the chemotherapy process itself.
Yes, and it is understood. You know, when you're put on chemotherapy, lots of changes are going to take place in your body, and these changes are systemic. Why do they take place? Because as the chemotherapy drugs fight your cancer, they also do damage to the cells.
To your body, yeah.
So you have fast producing cells, like the cells that are lining your digestive system, all the way from the mouth to down there. So you get patients presenting with sores in the mouth. They cannot swallow because they have sores in the food pipe. They have diarrhea because of, you know, the walls of the small intestine where absorption is supposed to take place are wiped off by the cancer cells. And then now you have hair falling, particularly for women. It's quite devastating for women who keep their hair. And then you have something we call bone marrow suppression, because the bone marrow cells also replicate very fast. Yeah, so it is a whole range of side effects profile, and it is systemic. Yeah. Okay. And by systemic, I mean that each and every system in the body, be it the breathing system, what we call the respiratory system, be it the heart system. You know, people are so worried about hair falling, but doctors are so worried about how much, for example, a drug called doxorubicin is going to be in your body, because if you get an excess, then you get something called cardiomyopathy. We will take you into remission from, for example, your lymphoma, but then you are terminally ill from now, a heart that is not functioning well. Or your bone marrow is so suppressed, you are hardly producing white cells or red cells, and you will be very tired from the anemia because of lack of red cells, or you will get a fatal infection from arising from an low immunity, because your bone marrow cannot produce enough white cells to fight for you. So even a simple thing like a common cold will take you down. Yes.
Okay. So that is to say there is so much more good that chemo does compared to the side effects that cancer patients tend to struggle with, yeah?
Absolutely. Chemotherapy is also a precise science, just like radiotherapy. We need to know the patients that we are subjecting to chemotherapy, what stage is their cancer, our goal of putting you on chemotherapy. Is it palliative, or is it radical treatment? And if it is radical treatment, is it together with radiotherapy, something we call concomitant chemoradiation? You will come across these patients who tell you, I am going on the machine every day, but each week I get a drug. That one we say that is concomitant chemoradiation. And when you have concomitant chemoradiation, your side effect profile goes up, and you need to see your doctor very closely. And so it is a whole profile of side effect that patients need to understand before we start on treatment. Not every patient qualifies to get chemotherapy for one reason or another. If your bone marrow is not working well, if your kidneys are not working well, if your liver is not working well, then it is a time to make them be better before we continue with the
with chemo. Yes, sorry, Esther, I have feedback for you here from Carol Karaoke. She says, very impressive, excited to see cancer in Atiba. Yeah, I think that's for you. Very encouraging. Yeah, so you start chemotherapy and your greatest fear was hair falling off. Daktari here says there's so much more that doctors are concerned with and so much good that chemotherapy goes to do in treatment and management of cancer, and that we should worry less about the falling of hair and other small and other side effects. But you went through it. So what was your experience like?
Well, now when we embarked on treatment, of course, with the surgery, my blood was quite low. So I had to get a transfusion first. And then now, during surgery, they say now they found it had moved to the fallopian tube.
It had spread.
Yeah, it had spread. So after the hysterectomy, Daktari, now I was put on chemo after. Yes, so now that is now where the treatment actually begins, for us. And it was, you know, the first one, when I went through it, I
first
felt
session.
like...
How many sessions did doctors recommend for you?
6. I felt like they had been lying about chemotherapy because I walked out walking and I was just fine. So I said,
I can do
it
this.
is just this small thing people are afraid of. So, but as I went on, I realized, oh, it is not as easy as it seems, because then now the things started changing. The weakness came in.
At what session now? At around the...
I think for me, it hit right at the second one.
At the second
at the
session.
first one, it started before I went for the second. So the second one, I lost my appetite a bit. The nausea started. And with this treatment, Daktari will explain that they prescribe drugs for the nausea. Then the drug that they've prescribed they prescribe the drug for pain, which of course now causes the nausea. Then they give you the drug for nausea, which gives you indigestion. Then they give you the drug for indigestion, which ends up giving you diarrhea. So it's like that.
It's like a vicious
It's like
cycle.
a vicious cycle. So you're always sick. If you stop the drug which helps you with nausea, it means you go through the pain. But then again, if you stop the drug now that helps you with the nausea, then you suffer even more. You're always in the toilet, throwing up, not able to eat.
You're not able even to apply yourself, let's say at
Exactly.
work.
And there's pain in the body. It's just that people don't understand. I wasn't able to take a shower for 5 days because even that water felt really painful on my skin. I felt like I was burning at most times. Because my kids were young, I tried to hide so much of my pain from them. And my son was 6 years at that time. He quite didn't understand, but he knew I was sick, though he didn't understand what it was from. And as a mother, I'll tell you, with experience with treatment, you don't stop being a mother. See, even when you're lying on that bed, sick, you can't get up, your child will still come to the bedroom and ask you for money for bread. So, as a patient, you choose on what to live for. You decide, this is why I'm fighting. I'm fighting because these are my children. And I'm fighting because if I succumb to this, then who takes care of them? So you put them first and proceed with the treatment. And that is what happened for me. Unfortunately, I wasn't lucky to keep the father of my children. He somehow disappeared, and
it's strained your relationship.
Very,
we'll come to that, but I want to bring Rose in. We have situations where a patient who's in for radiotherapy has also scheduled chemotherapy. So how does that work? And how do you manage as professionals in the field to ensure that it's a smooth process? And I want to imagine at times you'd go out of your way to just offer even support that is beyond your job description. Because assuming a patient has chemotherapy, let's say once a week, and radio every other day, and they call you and they tell you, Rose, I'm on this side of chemo, but I need to come to radio. Like, what sort of support does it take professionals like you to ensure that patients who are doing both chemo and radio are able to go through the treatment?
What I would like to say is, it's often, actually, like most of the treatments that we do see, except maybe breast, okay, the cases like breast, those ones don't get to go hand in hand with chemotherapy. But most treatments that we are giving radiation, they have to do with chemo concurrently. Luckily, it's just once a week for the chemotherapy. It's not a daily thing like radiotherapy. So if the patient is going for chemotherapy, we are in the process. We have to know. We talk to the patient, tell them to start early for the chemotherapy and then come for radiation after treatment. There are situations where the chemo is given for 24 hours. So at times then they have to come early to us, and then the following day you have to wait till late. So we've gone beyond our working hours that we can extend after the working hours to stay back and treat this patient, because you know the importance of treating the patient after chemotherapy. So you can't just assume that it's late, it's 7 o'clock and I have to go home.
Beyond my working hours, yes.
So we can't just close out the day like that. We have now to look back and say, what are we offering for our patients? We want the best for them. And even now, going just slightly beyond, other than just the treatment, when I was a student in Cape Town, what we were doing, we were even going to an extent of contributing for the patients, because they come late, they don't have treatment to get back home. So we have to contribute. We were doing on a Friday contribution, give some money for the transport once they have been treated. It's a journey, but then we are in it together.
Yeah, Dr. was saying you become very close friends with cancer patients. Yeah, best friends, I would say. Dr. we have feedback here from Moses and Ndege, my colleague. He says, I believe early diagnosis and proper counseling are the first and very important steps towards progressive treatment and healing process. Now, early diagnosis is a conversation that has been tackled in very many platforms, Dr. But my question now would be, after early diagnosis, I would imagine doctors want immediate treatment or also early management of cancer. But when we look at the infrastructure we have in the country, for instance, here in the North Rift and in Western Kenya, we only have one radiotherapy machine at government facilities. So how do we ensure that early diagnosis goes hand in hand with early treatment with regards having infrastructure to treat people? Because you'll find a cancer patient who's been recommended for radiotherapy at Moi Teaching and Referral Hospital being told, come back after 3 months, come back after 4 months. So we have early diagnosis, yes, but there's a challenge in early treatment, Doc.
This is a very important comment. Important in that most cancers, if we had screening and early detection, we would be having cancer survivors as living as long as 20 or 30 years
like Esther here.
Post-diagnosis.
Yes.
Because, you know, when you get cancer in stage 1, stage 2 disease, basically is curable with the very limited resources. However, I am so happy and actually very excited that now we have radiotherapy machines. West of Nakuru.
Yes.
2-3 years ago, before Ekura came into being, and then subsequently MTRH brought their LINAC machine. The only radiotherapy machine was in Nairobi,
at the
Kenyatta National Hospital. Then the next one was in Mulago, in Kampala. Now you can imagine that distance. So in North Rift, particularly in MTRH, we are very happy. And I would want to tell you that we are actually installing a second LINAC machine in MTRH. So in Eldoret, in the next few months, we will be having 3 machines. 2 at MTRH and 1 at the Eldoret Hospital. That is such a big improvement. The reason why the patients will come and they're told, come after 3 months, because you've been worked up, we have a diagnosis, we have a stage. But then when you go to the radiation machine point, there are other people waiting. Like we are told you that it's done in sessions. So we can't stop your session, Wangoi, because somebody else has just come and needs to start. No, your station continues to.
It has to be non-stop, but once you start
to
the
completion,
sessions, yes.
Because of something called radiobiology. You know, the radiation acts on the cells to suppress or stop their growth. If you stop the radiation, they start again, and now they start multiplying viciously. So that radiobiology has to be taken into account, and it must be done according to prescription in time and dose.
Okay.
So you have to wait to begin. What is the challenge of waiting for 3 months? If you are at stage 2 disease, potentially curable and going into remission for quite a long time, probably when you come at the 3rd month, either now you are in stage 4 with a worse outcome, or your disease has spread beyond. Now you won't even benefit from. So in this election year, I am not a politician, but if you are, whoever is vying is not talking about health, and particularly is not telling you what they are going to do with improving cancer therapy units, then don't vote for them. Yes.
Okay.
Well, and allow me to just add on to what Daktari has said, because now I'm speaking from the point of view of a patient.
From the horse's mouth.
You see, now the doctors do what they can, because you've gone you've had your diagnosis, they've seen you, they've given your prescription, like for radiotherapy, you're ready to begin. She's done her part, the patient is ready to begin treatment. Then you go at the radiotherapy unit and you find that it's in June. That's the earliest date you can get. So it's not because you don't want to start treatment, and it's not because the doctors have not done their diagnosis. Okay. So see now what happens with patients, and let me just be very frank about this, and that's why I'm not very happy with what is happening with these politicians who make a lot of noise, like Daktari said. A patient will come all the way from West Pokot.
Okay.
Daktari will attest to what I'm saying. This patient does not live in Eldoret. This patient has nowhere to sleep when they come for the sessions for radiotherapy. Say, for instance, it's 30. It's the 30 sessions, So you can't ask a patient from West Pokot to go back to West Pokot and come back tomorrow. So they need a place to stay. They'll need a place where they can be comfortable, because and a caregiver as well. So what fails us now, as I speak today, is accommodation for these patients, and that is where now, as survivors, have come out, because now we are hosting these patients in our own houses. As we speak, I have one in my house, because they have nowhere to go. Most of them used to sleep at the emergency section in the hospitals, and you find now it's no longer easy for them to be there, because then they're asked to leave the hospitals. Also, being in hospital, also you can pick quite an infection from something you are not expecting to have. So it's a challenge, and that is why these patients give up along the way, not because they do not want this treatment, but because when you're looking at the cost of what already, if you don't have NHIF, you're looking at the cost of what you want to pay, then you want to add accommodation into it. Remember, you have transport, and you are two, because it's the patient and the caregiver, and you also have to eat in the process. And remember, these people also have families back at home, and probably they are the sole providers. So when you sit down and think about it, most of them now give up. You find if a person was scheduled for some kind of treatment, they don't show up anymore. And some of them just come for after diagnosis, and they are given, and they can't afford this payment. So if there were more facilities,
and that also delays
and that
the intervention.
Exactly. So like Daktari says, if there were more facilities, like more units for radiotherapy, and then also again, I wish the government would embrace cancer like they did HIV, because then it would be easier for those ones who are needy
to get support.
We wouldn't need to host these patients in our own houses. There'd be facilities. As we speak now, there's only, I think, Rescos that offers these accommodation facilities, and only, of course, if you can afford it and if you have NHIF. Others have been known to be open, but I think they charge for accommodation.
So there's a huge cost implication.
Very, very huge.
That comes with
yes.
cancer
So
treatment.
it's not the doctors and it's not the patients.
It's the government.
It's the government that is failing us. Yes.
Rose, I want to imagine you experienced this firsthand. A patient has been told you need to do radiotherapy, you need 30 sessions, you need 23 sessions. And like Esther says, patients are really open-minded, most or largely, towards accessing and getting treatment immediately. So they come to your unit and they say, now, Rose, I need to start immediately. Because this intervention, I have early detection, and I know it will end well if I start early intervention. But then again, you have a huge queue. Tell us, how do you handle all that? And paint for us a picture of if someone has been brought to you after diagnosis by Dr. Sarah here and they need radio, how soon can they begin treatment at our public hospitals?
Apparently, my experience has only been in private hospitals. I've not worked in public institutions. But I know that it has happened in public institutions, that the patients come and the queue is just too long for them. They're given the appointment maybe 4 months to come. But I do understand they don't have money to go to private hospitals. But in my practice, private hospitals where we've been, sometimes we get that surge as well, but it is still manageable. It's easy for us most times that we do alter our schedules. We have been treating, let's say, from 8 to 5, then we will want to adjust our schedules to start even at 6 a.m. to close at 10. At least we are able to accommodate. I can't remember an instant where in a private hospital a patient has come and we have told them that we can't accommodate you. We are always trying to do that. But I do understand, I think, the challenge with the government institution is now the cost implication that it comes when they want to move to the private institution. So
how much is a session for radiotherapy at a private hospital?
Most private centers currently are charging 6,000 a session.
6,000?
Yes. And NHIF is, if you have NHIF, it will pay 3,600 for one session, for only 20 sessions. So if a patient is going for like 35 sessions, they'll pay 3,600 for 20 sessions. And then the remainder the patient will be will complete. But for 3,600 again, they have to top up by 2,400 per session. I know in public institutions like Kenyatta National Hospital, Kenyatta University, and now MTRH, they're just taking the NHIF rate. So I think that thing is really putting us down and is overburdening the patients. But I don't know how the balance will come about because radiotherapy services themselves, the generation of the radiotherapy service is quite expensive. So then I can't say who is who on in terms of charging. But I like the fact that the government is now doing something. We have a center coming up in Nakuru, Mombasa. I believe that is going to debug.
To get easier, because Dr. I want to believe health is a basic human right, and it should not mean because Rose here has 6,000 Kenyan shillings, and I have 100 Kenyan shillings, and we have both gotten diagnosed with cancer, then she is more qualified on the basis of what she has in her pocket. It's very sad.
You have to remember that nobody knows they are going to come down with cancer, so that they prepare that money for treatment.
True.
And it is a massive expense that is cropping into your normal expense. For an average Kenyan income, cancer treatment is out of reach. And you know, it is so interesting. Why would NHIF say we will only pay 3,600 per session? While if you are going for surgery, they will pay for the whole surgery. It's so intriguing. I have always asked myself that question.
What informs that? Yes.
Like they will pay for a whole knee replacement. They will reimburse a hospital up to 120,000.
Oh, wow.
and they will fail.
And that may not have a terminal scare. And
It is actually not okay. It is very inconveniencing for the patient. I appreciate it. It's a very difficult thing for the patient. But why would they not pay for this patient 6,000 shillings, the whole of it? Not so many of us are able to afford even 3,000 shillings per day for whatever. Me included. You know?
True.
So we are failing in advocacy, and we are failing in implementing the serious things that are surrounding cancer treatment. Let us budget very well for health. When we budget very well for health, actually, if we just go by the Abuja Declaration of putting a certain percentage of the country's GDP to health, then we will have enough resources to take care of each and every one of us. It wouldn't matter if you're a millionaire or if you are a pauper, because there will be universal health care. I have cancer of the breast, I go to any facility, I am sure I'll get the doctor, I am sure I'll get the drugs, I am sure if I need radiotherapy, I am sure I'll get the surgeon, whether I have that money or not. Yes.
Okay. Very interesting. And
before you cut me off, I would like to say that even doctors, the salary that a doctor gets in this country cannot afford cancer treatment. If you come to our walls, we are constantly contributing for colleagues. Yes. And it is a very sad scenario, you know, to ply a trade that you cannot afford.
I know. I know. And if for those in employment and for those with business ventures or something to do with their lives, it becomes expensive, then how about someone who's totally not employed, or they do not have a business running somewhere? And you see, gone are the days when we'd say cancer is a disease of the class of rich. Esther, I want to believe you have had experiences with Kenyans who are really struggling and with barely enough for themselves and being diagnosed with cancer.
Well, let me first start by saying that for me, just come to Eldoret during my diagnosis. I was so new. I'm also in the medical field. But I'd not started earning quite well. I just come to Eldoret, and
you were trying to find your footing financially.
Find my footing financially.
And then the cancer burden comes.
And then the cancer burden comes. I am in a new town. I don't know anyone.
It was tough.
At first you start using your own savings as well as your NHIF, and I had one more this private health insurance. But you know, people assume that when you have all that, that it can pay for everything.
For all the costs that you need.
Rose will come in to this point, but there was a time that Jubilee Insurance was the only one paying for radiotherapy. The other private health insurances were not within Eldoret Hospital. So NHIF was the only best option. And then now with the number of limitations they've put, now you have to go back to your pocket. Yes. So you see now with this treatment, it's not like it's only the chemotherapy you get. You're also having scans in between there. You're also having lab works in between there. And you're also having drugs that you're buying, that you're taking orally. And they're not cheap. Yes. So it's strainers now for somebody who has a job. Now imagine for someone with
who
nothing,
is lacking,
no NHIF, and no source of funds. So you depend on friends and family. And I'll tell you firsthand that people get tired. Cancer is a continuous process.
Your journey began in 2015.
Yes.
And you're still managing the condition with treatment.
And there are people who will come and ask you, Yani, you've never gotten better? Hujawai pona? Things like that. And with cancer, there are always something that will come up without your knowledge. Yes, like you can have a certain complication that you need to run to the hospital
doctor again
for.
Thank you, Esther, for that one-on-one. Really, Esther painting for us a picture on cancer treatment and the financial implications and burdens that come with it. We take yet another health break. When we come back, we talk matters cancer and research and how far the medics are with regards cancer treatment and management. We take a short break. We'll be right back with that and much more.
Kila zuri lina kafara yake.
Burgers for $6. Did you say 6? Fungua app. Ding dong, double. Your favorite moment.
Now your favorite ice cream.
Ding dong, double.
It's so good.
Order what you want to select what you want. Ding dong, double.
Order it now. Download the app, order a Glovo, and we get it.
Ding dong, double.
At the first sign of pain, you need a solution that you can trust. Try Panadol Advance. With Panadol's Optizode formula, the tablet absorbs quickly and starts providing fast and effective pain relief you can trust. Try Panadol Advance.
In the house that night when I came to see her.
Yeah, but you left her. You guys need to stop.
She's my woman.
Calm down, Bob. Look, she agreed to be a couple.
It's lunchtime. Just go. Just go. It's okay.
What is wrong with you? Why did you do that? Why are you even here?
I should be asking you that.
Get peace of mind and protect the ones you love with the power of Dettol Bar Soap. It cleans and protects from up to 100 illness-causing germs. So no matter what type of mum you are, trust Dettol.
Who is this guy? First feedback I got was he's very fast.
The world will be looking at Ferdinand. I saw the African record going down.
Kama mzazi lazima ufurahie.
I don't know what I was doing in volleyball, but it took me like a month or two to now accept myself that I'm an athlete. Unajua wanasemanga hivi ingia gym na bado uvengo bagi. Lazima muscles zionekane.
My name is Ferdinand Omanyala and this is my story.
Ili tuendeleze maisha bora kwa ajili ya wapendao, nchi yetu na usoni wetu, kwa ajili yetu sisi sote. Pata chanjo, kaa chonjo, kuhakikisha nchi yetu na uchumi wetu umestawi katika uwazi. Tusirudi nyuma.
Welcome back. Our conversation this morning being understanding cancer treatment. We have been having that discussion with my guests here. I have Dr. Sarah Obuya, if you're just joining us. She's a clinical oncologist. Esther Andare, a cancer survivor. She was diagnosed with cancer, ovarian cancer in the year 2015. She's here alive and doing very well, I must say. We also have Rose Ekesa, our radiation therapist. Before we went to the break, Doc, I had spoken to you about the issue of research, but I want us to hold that thought and first of all talk about human resource. This is yet another important infrastructure in cancer treatment. Rose, let me start with you. Do you have enough of your kind, radiation therapists in the country, and what need is there to ensure that human resource is improved as one of the supporting factors in cancer treatment and management?
Okay. Probably to speak on the line of radiation therapies, for some time, maybe until just 2 years ago when Nairobi started training for radiation therapists. Initially, it was a real shortage of radiation therapists.
Okay. Where did you train yourself?
I was in South Africa.
South Africa.
Yeah.
Okay.
But since I can't even remember, 2012, the International Atomic Energy Agency, together with the Kenya Medical Training College and Kenyatta National Hospital, started a training. They were doing a higher diploma in, if you did diagnostic radiography, then you would do a higher diploma in radiotherapy. The challenge that was there, I think, at that training, we also had students, but then the infrastructure were less because we had only 2 institutions at that time. We had Cancer Care Kenya in Mpisha and the Kenyatta National Hospital. So it was not accommodating enough students. Besides, then we were also getting students from neighboring countries like Malawi, Uganda. So that training is there now. It's boosting, but we're still not in a capacity to say that we can handle the cancer burden in the country. For the few institutions that are currently running, I think they've tried to scale up the human resources in terms of radiotherapy. For us in private hospitals, there are recommendations by the International Atomic Energy Agency, the number of staff for the number of patients, but sometimes it outweighs the other. So we have to, somehow I can say we are overwhelmed with work, but then we are in it, so we have to keep going. I know at, I think, MTRH we have 6 for the 1 unit, but then they're coming up with more. Another unit is about to come, and we have treatment planning, so that already is not enough with 1 medical physicist. But then I don't know what is happening. Maybe Dr. Sarah will mention to us about it.
Dr. Sarah, you want to touch on that? The human resource infrastructure that we have in the country vis-a-vis the cancer treatment human resource needs.
The cancer human resource needs in this country, to the best of my knowledge, is underwhelming. For example, to the west of Nakuru, we only have, up to until last year, we only had 2 oncologists who could administer radiotherapy.
My God.
Now we have grown in leaps and bounds. And now we are 6. What's the population of Western, Rift Valley, and Nyanza? Now you can imagine.
6 only.
Yes. 6. And every day we wake up, like now the way we are woken up, when I'm from this studio, I'll go to the Chandaria Cancer Center. We will be having more than 15 patients newly diagnosed with cancer. And newly diagnosed, not the ones that are undergoing treatment. And out of these 15, it's not that there are 15, there are more than 15, but that 15 new patients is what the doctor can handle that particular day. So what happens to the others who similarly needs to be seen? And the doctors are few. In MTRH, we have been 3 of us. But now one of us is going into politics. We are really crying. We have told him, please, Daktari, just continue being a doctor. And then he's telling us, no, I have to go there and make policies so that things can change for you guys. So then technically, we are 2.
You will be 2 at NTRH.
Which means this year I am already psychologically prepared that there's no annual leave for me. And there's nothing I can do about it. Yes, because it is me and the head of department.
Wow.
So, you know, as soon as you wake up, for the weeks that you are on call, sometimes the calls wake you up. So we need doctors to train in oncology, and particularly clinical and radiation oncology, because we cannot purport to be opening radiotherapy centers and we do not have doctors. Having said that, this country is very unique. There are individual doctors who have gone there on their own, they have trained, and they are clinical oncologists and they are radiation oncologists, and they have no jobs.
Wow.
Because the government cannot employ them. The private sector machines are very few. So you get that irony.
Okay.
I know at least 3 or 4 clinical oncologists with no jobs.
Yet ready to serve with all the knowledge.
They are jobless, having been in school for more than 15 years, and yet there are patients who require their services each and every day. So the policy on human resource, particularly for training of radiation stroke clinical oncologists, needs to be worked on. And we need to produce enough for our population. I understand we are a third world developing country. We have financial constraints, but just the same way we budget for elections.
Yes.
Have you ever woken up one day and found that elections cannot take place because there is no money?
There's no money.
No. Just the way we budget for elections, the way we budget for education, the way we budget for transport is the same way we must budget for human resource in cancer. Currently, it is underwhelming and shameful for our country. Something needs to be done.
It's very sad.
And when you are doing this, you must make sure that as you train the doctor, there are people who work closely with the doctor, like the therapist, like the nursing oncologist. Because you see now, the nurses who take care of oncology patients, they are not the normal nurses. They have gone and super specialized in nursing oncologists. Yes.
Right.
You have the radiotherapists, you have the radiation technicians, and then you have a very important person in the radiotherapy unit called the physicist. Even if I prescribe radiation, how? And the physicist is not agreeing with it, of course, on scientific basis. That treatment will not go on.
All right.
We have only one physicist in MTRH. So it means this guy cannot even fall sick. He can't even get a common cold. He can't go on leave.
He needs to be very protected. I want to believe also.
In short, he can't even leave Eldoret. Because how does he leave Eldoret and somebody is going to come bleeding from with cervical cancer and needs to be put on the machine?
And if for the call of nature he's taking some sleep, that means no treatment is happening in this side of the country.
He will actually have to reschedule his breaks to fit
the patient's register.
Yes.
My goodness, my goodness. Okay, a bit of feedback coming here. We have Amos Temo. I've at one time thought of going for it. Oh yes, this is with the question we had asked our viewers, have you ever gone for cancer screening? So Amos says, I've at one time thought of going for it, but I don't know from where it starts. The screening, is it available in all hospitals around Amani Church too? Daktari screening available in most public hospitals?
Oh yes, in my hospital. Our CEO has worked very hard, and right now as we talk, you can walk into MTRH and get screened for cancer of the cervix, cancer of the breast, cancer of the lung, prostate cancer for free of charge. Just walk into Chandaria Cancer Center. But then anecdotically, we also have campaign screenings. We have systems put in place that every so often we go to counties and it is announced on radio and TV and the print, electronic media that on this day and this time we will be in this place and we will be doing screening.
Good. Okay. Lillian Mokera Cheptos says, yes, I did cervical cancer screening. Alex Kialo says, no, but with time nitajikaza nitaenda too. And I want to bring in Rose. You see, like what Alex Kello, he says he's still gathering courage to find his way to this cancer screening. From private facilities where you work at Eldoret hospitals, what are the trends? Are you observing more and more walk-ins, voluntary ones, coming for cancer screening, or is there a need, like Daktari says, for us to continue having these campaigns and targeted audiences in encouraging Kenyans to get screened for cancer?
I think just to be direct, there's need for campaign and to create more awareness to our people. Maybe just to elaborate a little more, I've been in this side of the country, and I noticed that most of the patients coming are presenting at advanced stages. So screening is a bit not, well, I mean, it's not in people yet, but we really hope they are going to see
going
that,
to come.
yeah.
Okay, we have Madan Daniel. He said, I have done mammogram and pap smear, but I don't think I can do it again, especially mammogram. This is the experience of Madan. And in the matter of cancer treatment, Esther, cancer treatment gets to a point where, I don't want to say your dignity sort of stripped away, the dignity of the patient is sort of stripped away because the whole process is very involving with the health practitioners or even with the caregivers. You said there was a time you could not even bathe yourself. So I want to imagine there was someone who was stepping in for that. So the need for palliative care in cancer treatment, how important is it for us to show care, moral support, financial support, and even mental, psychosocial support to persons going through cancer? Esther?
So let's start with the point of now screening.
Yeah.
So there are myths, of course, as after now the journey and with now the encouragement we are trying to get to others to go for early screening so that they don't end up where some of us ended up. There are myths surrounding cancer. My experience has been in Western Kenya because that is where now I do my advocacy most. And you find that there are people who still think cancer is a communicable disease, that you can get it from simply living, if it's a spouse, living with your partner. And there are people who have been chased out of their homes because people think this is a terrible disease. And then there are those cancers that, quite frankly, let me use which word, brings you shame, like cervical, vulva, because there are always some odors coming with it. So you are unable to sit where others are. You are unable to quite relate to other people because there's always that mentality that they can
the patient
actually,
gets very uncomfortable.
Yes. So you don't end up saying it. And there are people who cannot understand why you are in such a position. So they'll think for some partners they have been accused of infidelity in the process, been chased out of their homes. And for some, for those ones who merely don't understand it, it's been considered witchcraft. So they found other means to go about it. So the awareness part is quite important because then again, people are made aware that this is not witchcraft, and it's not infidelity and such, so that now when they're coming, the fear is less. And I find that most men, when it comes now to the prostate side, men are generally held back. They do not like coming for screening, especially for prostate. I may not understand the main thing why, but I just know they have the fear of being checked. And most of them, when they come, maybe it's at an advanced stage, or they come in because they have their prostate have actually enlarged. So from my experience, there's need for that awareness so that people understand that now when they see this patient, they're supposed to actually assist them in their journey towards treatment because it needs a lot of things.
A lot of support,
physically, financially, emotionally. There are people who have wanted to take their lives because of this treatment. There are people who financially, they've been unable to do it. So it's if we all looked at it in such a way that when I am affected with cancer, then we all
are affected
with it. Then again, I think we'd find the best way to go about
to show
it.
Support.
Because myself, I fortunately, I got friends. You lose friends, by the way, because I lost quite a lot of friends. I had to get a new set of friends who came in, and people are not quite the same. There are those ones who don't feel as deep as others. So those ones who came in helped throughout the day. Patients just generally need to be shown
support,
love.
and support.
When they've actually accepted that now they are sick, then they need that support. They need to be shown that we are walking this journey with you, so you move along. Yes.
And Rose, from where you sit, Esther here talks about some cancers that can be very uncomfortable, especially those around sexual reproductive organs, let's say cancer of the vulva, cancer of the cervix, or even prostate cancer. As professionals, are you trained in how to manage these people? And really, allow me to say this, some people feel like some health practitioners can be very, very unkind and very unfair. So how do you ensure that as you're giving your medical support, then you're also offering the moral support that comes with it? There's something I saw on Facebook, a joke the other day. Someone was saying, say something nasty a health practitioner has ever said to you. And in this case, they were talking about nurses. So one guy said he walked into a health facility and he was very unwell. So he was trying to support himself on the walls like this, using his hands like this. So nurse akamwambia, kuja hapa Spider-Man, songa huko Spider-Man. Yeah. But the need to ensure that you serve cancer patients with dignity, especially with cancers that can be very involving of their bodies that they may not be comfortable with. How do you handle that to ensure our cancer patients feel comfortable?
First and foremost, probably just to say, I think training of these professional cancer care givers is very important, because in the training you go through all those stages and you get to be taught how to handle the patients. So if a person is well trained and qualified as a cancer caregiver, then they should not be able to speak like that. But being a caregiver in cancer management, myself, I can say, you really need to put yourself in their patient's shoes. Imagine you are the one now being told that. And for us in radiotherapy is a bit even unique, because these patients are with you for a long time. Speak to them like this today, tomorrow they're there to face you. So you need to know how to handle them and just make them feel that whatever they're going through is not unique to them, is something that happens to people, and try and clear their mind. It's most of the time is just talk and talk and talk, the same thing, repeat to them until they get to take it.
Dr. I have an SMS here from Josephine Kiganji. She's asking, is cancer curable? Just ask Daktari, is cancer curable?
Yes, it depends on which cancer and which stage. But in cancer care or oncology, we don't talk about cure, we talk about remission. And remission means that we have adequately controlled your cancer and we have belief that it will not reoccur. So therefore, yes, some cancers are curable.
Esther, I think you're best placed to also do some contribution on the same. Josephine here is asking, and Taka to address, is cancer curable? Just that, yes.
I believe I am a very good answer to her question. I am still here, having gone through the treatment. And I'm not alone. We are quite many who have gone through it, accepted the treatment, and gone through it, and still here. So with cancer, it's generally just the beliefs that have been there around it, that probably it is death, that is the end of it. But that is not the case, because once you accept treatment and you follow your treatment in a good way, just like the doctors tell you, I believe with time now you find that your body also adjusts and you start picking up. And if you had lost weight like I had done, I was weighing, I think I was weighing almost 45, I think. I lost quite a lot. I wasn't able to work. Last time I was here at Nation Media, I was using crutches. So, but you see now there's a difference because I gained the weight. The hair that I was so afraid to lose grew back. And the hair doesn't really fall off all of it. It always falls off in patches. So you're forced to cut it because you want it leveled. It just doesn't shed off like
you wake up tomorrow.
Manyoya ya kuku. It's just patches, and it thins, and now you have to cut it. But if a cancer patient decides that it is the willingness to take up that treatment, and the faith also that that treatment will work. Because also the way your brain works is that if you have a headache and you always take Panadol Extra, and you're given, say, mara moja, that headache might not go because your belief is that Panadol Extra ndio itanisaidia. So it's the belief you have, the mentality you go in with is what actually determines your
So you did surgery and chemotherapy, and are you currently on medication?
I am not on medication now, just reviews. And I am hoping that this year there'd be a doctor here will give me a clean bill of health, and then now I can start moving about like the monster is gone. Yes.
Well done so far. Dr. there are also other treatments that are available, but I understand in our country, chemotherapy, radiotherapy, and surgery is mainly the options that cancer patients get. Now, we have some other forms of cancer treatment and management. One is bone marrow transplant, immunotherapy, hormone therapy, or targeted drug therapy. Talk to us about these solutions and why they're not as popular in our country.
Actually, we have all of them except bone marrow transplant. It's only bone marrow transplant that we cannot do here. The reason why immunotherapy is not... Hormonal therapy is quite accessible and easily available for breast and prostate.
For breast and prostate?
Yes. Immunotherapy is not famous, but it is available. We have Keytruda, pembrolizumab available, nivolumab available.
What is it?
The problem is the cost. They're insanely expensive. And it is not the cost of the drug only, it is the cost of the tests that will make you put a patient on that treatment. Because they have to have certain, your cancer must have certain genes. For example, melanoma, your melanoma must have a certain pattern of genes to be responsive to Keytruda. Not every patient with melanoma will do well on Keytruda.
That is for immunotherapy.
Yeah, for immunotherapy. And that test...
So in layman's language, what does that entail? Is it like
what
drugs?
It entails is that when you have cancer, each and every day the cells multiply. These cancer cells are very smart. They acquire certain things called genes. Those genes protect your body cells from killing the cancer cells. So you will have, like, let's say, we have Kenya, then we have KDF. We are here in Nation Media Group. We do not know that KDF is working, but in actual fact, it is working every second. There's surveillance. That is what your cells, your normal cells do. They are going around checking, this DNA is looking bad. This one is going to cause problems. Let's cancel it. Okay? Now, cancer cells have mimicked that to survive. They know if we have this DNA, then when the normal cells are doing surveillance, they will not see us.
They will not notice.
They will not see us. So we will continue multiplying. So the cancer cells are like Al-Shabaab. They are amongst us, they are living, but they have developed means and ways of surviving amongst us as they plan their evil ways. So now, immunotherapy is like that thing you call the rhesus squad. The KDF knew there's a problem. They are not quick enough to respond because they are not targeted to that place the event is taking place.
Very well, Doc. I'll come back to you on your closing remarks, and I would want it to be on cancer and vaccines. Yes. So Rose, your closing remarks as a radiation therapist. How has that contributed and impacted cancer treatment, the use of radiotherapy?
Okay. I think I started by saying when we see patients respond to radiotherapy while they're undergoing, it motivates us to keep going. So entirely, maybe I can say radiotherapy has contributed largely to keep the population. Yeah. And one of the viewers did ask whether it's curable. I've seen a person who has stayed over 25 years and they're still doing fine. So it is through the combination of treatments. So I know radiotherapy, if they go through, stick to the routines, stick to the instructions, and you'll be fine.
Yeah, thank you, Rose. Yeah. And also thank you for allowing us into your facility, Eldoret Hospital. We had an opportunity to just see how you're doing all these treatments, yeah, and we got that for our viewers. And our cancer warrior and survivor, Esther.
Well, mine is just to encourage the cancer patients because that's all I can do. The journey sometimes might seem long, but there is always an end to it, and it's just keeping up your spirit and knowing that even when a cough begins, after 2-3 days, it's gone. It's gone. So if you treat the cancer like the cough, you eventually know it shall be well.
Very well.
Yes.
Asante, time is not on the side. Dr. very briefly on cancer and vaccines.
Yes. Many of our, actually up to 30% of our cancers arise from infectious agents. And it is, science has proved that, for example, if you give vaccine to young girls and boys before they are sexually active, then you significantly reduce chances of them getting cancer of the cervix and cancer of the penis. Yes. So it is very important. Vaccination is very important in the control and prevention of cancer.
Asante sana daktari, asante sana Esther, our cancer warrior, and our radiation therapist specialist, Rose Wekesa. Tunasema asante sana. So much feedback coming in, and really our viewers appreciating that they now have a better understanding on cancer treatment. Remember, daktari here says it needs not to be a death sentence. With early diagnosis, early management, and treatment, one can lead a happily ever after life. Like Esther here, 2015, diagnosed with ovarian cancer, went through chemo and surgery, and today she is a cancer survivor and warrior going about her duties. That should be it from us from here, our Eldoret studios, concluding our program of Your World this morning. I want to wish you a pleasant Tuesday. Please stay with NTV. We continue turning on your world. Enjoy our Tuesday morning programming schedule. Later, we'll be coming to you with NTV Sasa in 1 p.m. With news updates in real time and those expected to develop later in the day. Tuesday afternoon scheduled programming is also quite interesting. And later at 7 p.m. and 9 p.m., all the day's works of my fellow colleagues during our bulletins will definitely have something good for you. Yeah, my name is Lois Wangoy, and I want to say asante sana for joining us this morning.
Thank you.
Mortein Doom All Insect Killer provides protection in seconds. Not even a single mosquito is spared, because even one mosquito bite can cause malaria. Mortein Doom provides protection in seconds.
In your paper this week, Kenya concerned over Somali's nullified oil bid. Kenya